morning, everyone. I'm Susan McKenzie, and this is an Insight Conversation hosted by the Emergency Services Foundation. It is being recorded and it will be available on our website later in the week. I'd like to begin by acknowledging the traditional owners of all the lands we're on today. I'm down on the Mornington Peninsula, so it's the coastal people of the Boon Wurrung and Bunurong people, the traditional custodians of the beautiful lands and waterways around me. I'd like to acknowledge their elders, traditional owners and emerging leaders today. We started doing these conversations about 12 months ago, and we've received terrific feedback about them, and I'm sure this one will be no exception. The Centre of Excellence for Emergency Work and Mental Health certainly rings a bell with me, but what exactly is it and why is it so important? Today we've got David Forbes. Professor David Forbes is the Director of Phoenix Australia Centre for Post-Traumatic Stress and Deputy Head of the Department of Psychiatry at the University of Melbourne. David is a clinical psychologist with extensive experience in the assessment and treatment of mental health problems following trauma. He led the development of the Australian guidelines for the treatment of acute stress disorder and post-traumatic stress disorder. He's a passionate advocate for the use of evidence-based responses following trauma. And Phoenix Australia has been appointed to operate the new Victorian Centre of Excellence for Emergency Work and Mental Health. So who better to tell us all about it and get it straight, what it is, what it isn't. And so over to you, David.
Thank you very much, Susan, and thank you very much to the Emergency Services Foundation for inviting me to speak today about this topic. I hope you don't mind. I wouldn't usually use slides for a webinar like this, but in relation to the Centre for Emergency Work and Mental Health, it's got a lot of elements to it. So I thought to some degree, perhaps slides are best for a topic like this because it does have different components and parts, and sometimes seeing that graphically can be helpful. So next slide, please. So just a little bit about Phoenix Australia. I won't go on about us, but I guess why us in relation to the Centre of Excellence. So we are a National Centre of Excellence in Post-Traumatic Mental Health. We've got an internationally recognised program of research. We work with organisations and agencies federally and state-wise in kind of national security, first responder areas, defence, around best practice management of trauma in high-risk organisations at the policy end, at the practice end. And we also work to deliver training and education programs trying to build competencies around the management of trauma aligned with best practice. And deep links internationally in relation to the International Trauma Society, International Trauma Guidelines, and we co-lead with our Canadian counterparts, something that we've called the Five Eyes Mental Health Research and Innovations Collaborative, which is the Centres of Excellence in Military and Veteran Mental Health across the Five Eyes countries. We co-chair that with our Canadian counterparts, and that allows us to share knowledge around research, around practice across the Five Eyes nations. It has traditionally been in veteran and military mental health, but we're keen to expand it across to kind of first responder emergency work and mental health as well, in addition to national security. So next slide, please. And this slide, I guess, just to say that we do work in kind of three domains. In the policy and practice space in relation to what does evidence-based practice look like, working with agencies to embed best practice, as I mentioned before, training and being able to provide leaders and clinicians and practitioners and all those involved in the care and support for emergency workers with the skills that are required to align with best practice, and then a research arm to push the field forward in terms of not only embedding what we know, but being able to take the field forward in terms of learning more. How do we better help those who serve our community through emergency service work? And my reason for flagging this is that the Centre of Excellence in Emergency Work and Mental Health that I'll be talking with you about cuts across all three of those areas. It's got a policy end, it's got a training end and a research end. So thank you. Next slide, please. So in terms of just a brief orientation as to where this came from, so some of you may recall in 2018, the Andrews government then made an election commitment for about $14.5 million over a 5-year period, and that was to do four things. One was to establish an early intervention and prevention fund. One was establishing a provisional acceptance of payment scheme. 3 was establishing a specialist network level group of clinicians. And the 4th was establishing a centre of excellence in emergency work and mental health, which is what I'll be talking about today. So the first 3 of these were embedded first. And next slide, please. In March of this year, 2 months ago, the Premier announced the commencement of the Emergency Worker Centre of Excellence in Mental Health. And the process was taken really from concept to reality. It was initial conversations that were occurring with DHHS, with Department of Justice, with Beyond Blue, with Phoenix Australia, ourselves. We developed a set of draft service specifications. We consulted very widely across the field, across a broad range of stakeholders. We developed an advisory committee in relation to what these specifications for what the Centre of Excellence might look like. And the membership of the advisory committee, you can see there on the right of screen. So the health professional organisations, so the College of GPs, College of Psychiatrists, Australian Psychological Society, Australian Association of Social Workers, key players like Black Dog and Beyond Blue, the Emergency Services Foundation. So Susan sits on our advisory group, and a range of members with lived experience representatives who are able to then provide us with advice around the development, the setup, and now the implementation of the Centre of Excellence. Important to add also, Beyond Blue was a founding partner in the establishment of the Centre of Excellence. And now, next slide, please. As mentioned, the Premier announced it on the 4th of March at North Melbourne Ambulance Services. We were commencing this following on from that election commitment in 2018. Next slide, please. So what is this Centre of Excellence? And I guess this is part of the reason where slides come in handy, because it does have 3 component parts to it. Ultimately, what it's aiming to do is to build a platform to improve the capability of practitioners to provide high-quality evidence-based care for emergency workers with mental health problems. So the aim is around we're improving mental health outcomes for those who have served and are currently serving in emergency worker organisations. And it does so through building that capacity through 3 key objectives. So one is building the awareness of practitioners out there more broadly to meet the needs of emergency workers. So the broad array of practitioners out there in the community who support emergency workers across the disciplines, to provide them with information and awareness, including a multidisciplinary advisory service, so a secondary consultation service, multidisciplinary GP, psychology, psychiatry, social work, who's able to provide advice, secondary advice to those service practitioners in relation to queries they may have. Second of all, is to develop and evolve a specialist network of clinicians. So this is kind of narrows down more specifically now, develop a specialist network of clinicians to provide the core therapy, supported by a centralised intake service. And the third arm is really designing, delivering kind of research projects and evaluation projects aimed at really making sure that we learn from the outcomes of the clinical services that are provided and move that forward. So being able to provide what we call point of action research in relation to being able to learn what's working, learn how we can improve services and have that as a continuous improvement model. Next slide, please. So elaborating now on some of those key points of focus. So really what we're looking to do is making sure that we're embedding best practice treatment interventions. So how do we build the capability of practitioners, a core group of practitioners out there in the community, to be able to provide what we know is evidence-based best practice treatments for emergency workers with some of the common mental health problems that we know from research like the Beyond Blue Answering the Call research, from research our centre's done and our colleagues have done nationally and internationally, for things like work-related PTSD, depression, anxiety, as well as commonly associated problems. So things like significant sleep problems, anger problems, things that relationship problems, things that we know go with those conditions that can actually start to expand and spiral and really impact on people's lives. So what we're trying to do is raise the bar and ensure that best practice evidence-based treatment's available and provided and assured in these core areas particularly of these disorders, these conditions, and their associated problems. Critically, though, it's not the Centre of Excellence isn't a bricks and mortar operation. It's got a virtual focus, which is looking to ensure that there is the network of clinicians that operate across Victoria. It's operational, as I mentioned, as of March, and the current contract goes through to June 2023. And it's really looking to build that over the course of those first few years, and we'll talk about that shortly. Next slide, please. Expanding on the points of scope, so who's providing it, who's it for, and remembering that this is iterative, and so in the first phase, really the main users of the Centre of Excellence are going to be the practitioners in these areas, so psychiatrists, psychologists, general practitioners, mental health nurses, mental health social workers more broadly dealing with a broad array of psychosocial issues confronted by emergency workers with mental health problems, mental health occupational therapists, psychiatric nurses and occupational physicians. And the Centre of Excellence is going to engage with these professional groups within the scope of the practice in which they operate. So, for example, for GPs, it's going to be around the nature of the activities and clinical activities that the GP is likely to be involved with. With the mental health specialists, it's going to be a much deeper engagement around delivery of deep evidence-based treatments. And depending on what the practitioner group is, the Centre of Excellence will engage with them around their specific scope of practice. In terms, who are the emergency worker groups who will be in the first cab off the rank served through the Centre of Excellence? It is both employees and volunteers. It is both serving and ex-serving. It is those in operational and in support roles. So it really is for everybody. The first responder organisations or the emergency worker organisations that are the first cabs off the rank, in speaking with the department and ministry, we did need to decide together with the advisory group about and consultation group, which would be the first agencies involved, given that it couldn't be for everyone immediately, but we can imagine this is going to gradually iterate out. It was for Victoria, so current and ex-members of Victoria Police, Ambulance Victoria, Fire Rescue Victoria, the Country Fire Authority, Forest Fires, the Port Department of Environment, Land, Water and Planning, and their partner agencies, the SES and ESTA. We recognise that there'll be a number of you who might be seeing this webinar who may be members of emergency worker organisations who aren't part of that list. Critical to say is that we've got to be aware of that, and we do imagine this list is going to expand. Also, secondarily, that we're very happy to receive information, given what we'll be educating practitioners in is both the clinical competence in treating the conditions as well as the cultural competence. Having a network out there is accessible then for anybody. And if there is information about your organisation, if you're not listed there that you think it's useful for us to have in relation to what are some of the nuances about working with your organisation, if they're not listed, you'd like the Centre of Excellence to know about, we can also disseminate, please by all means let us know about that. Next slide, please. So in terms of functions and the major activities, so the first is really building the awareness and capability of the practitioners across Australia, across Victoria. What we want is to build a broad awareness and education program for all practitioners so that they understand around emergency work and mental health. They know what to look out for, both culturally within the organisations and clinically. They know what questions to ask, no matter where they're touching into the care of emergency workers in relation to their mental health. Provide them with a multidisciplinary advisory service if they're struggling or if there are questions that they have, and help them establish networks across the state, across their region, across their area, and then potentially across the state, and help them broaden out to having national and international networks. So we're getting that into play for all practitioners, but I feel like they're part of something much bigger than what they provide themselves. The second, as we delve into more deeply, is around developing the core specialist network of clinicians, where we'll have a centralised intake service, and we'll be establishing and providing formal training and education programs for those in the specialist network. Education training programs in training in the key evidence-based treatments and key interventions in those associated areas, core training in assessment and treatment planning, recognising that many folks will have those skills already, in which case it's a terrific bolster for the skills that they have, or alternatively, like for all of us, or all of us together, we find that kind of refreshing some of our skills and knowledge with what's the kind of the latest in evidence-based treatment can also be helpful. And then embedding a quality assurance mechanism to make sure that what's being provided is the best possible, and having that as a continuous improvement loop. And then designing innovative interventions in that third dot point, which is, can we put a small research framework around it, action-based research, so we can learn better about what for who as time goes on. At the moment, the field, in terms of what for who, we know that these treatments for PTSD, for example, are really good, but PTSD comes in many shapes and forms. There's different PTSD treatments to help us learn about how can we better match people to the treatments going forward so that emergency workers are getting the best possible outcomes. And of course, then there's an operations component of the COE as we establish our governance processes, corporate services to support it, etc. Next slide, please. So the current focus between now and June 21 is around starting to mobilise this. We've established the advisory committee, and we're starting to now map out the initial documentation around what's the awareness and education program going to include, what's the structure of the multidisciplinary advisory service going to look like, what is that competency framework for practitioners that will be negotiating with the health professional organisations that we'll be looking to embed, getting the best, most streamlined blueprint around the specialist network and the centralised intake service, and deciding on first points of action around a research framework. And starting, for example, like today, to start to engage in communications to the broader service network and the broader emergency network around what it is that's being planned. Next slide, please. Through this process, we've collaborated, as you can see from this slide, with multiple partners, multiple agencies, multiple collaborators, multiple stakeholders. If you don't see yourself on that list, please, by all means, reach out to us. If there's things that I've presented today that are queries that you have, please don't hesitate to reach out. The whole focus of this is to try and ensure that emergency workers get the best possible care in relation to mental health, and then anything we can do that aligns with the scope of the Centre of Excellence we're keen to do. And I really appreciate the opportunity that Susan, the Emergency Services Foundation, have given me today to talk about this topic. So I might stop there, Susan, and thank you very much.
Thank you, David. That's great. It was a really concise overview. I hear you were speaking fairly quickly. We've got two other speakers. I'll just say to people, in your screen there is a Q&A button next to the video, and I will facilitate questions. We have two other speakers to join us today, and we'll go now to Dr. Tony McHugh. So Tony's been the manager and principal psychological trauma recovery service at Austin Health. He has been responsible for the setup and development of psychological treatment programs for severely traumatised ADF and emergency service workers. He's an advisor on the WorkSafe clinical panel. He is in private practice treating trauma-related mental health. And he's also a senior policy advisor with the Australian Psychological Society and a member of the Centre of Excellence Advisory Group with me. So he's very well placed to talk to us today. So welcome, Tony.
Thank you, Susan. Thank you very much. And thank you for the invitation, and glad to be here.
Pleasure. That's great. Now, one thing David didn't talk about, and that was probably deliberate because I think you're perhaps better placed to answer this. As a practitioner, why is the Centre of Excellence so important?
So, as David alluded to, it's a purpose-designed Victorian government-funded structure for guiding best practice treatment of emergency services workers. And those workers may have emerging or early stage need for mental health interventions. So that's really important. It's important because, surprisingly, and it's a never-ending surprise and disappointment, best practice is alas lacking in the field. I'm speaking for psychology particularly, but I don't think it's limited only to the practice of psychologists. So thus what we know from eminent research bodies like Phoenix and Black Dog and the behaviour of field leaders, too often that evidence-based treatment is not implemented, and I see this frequently, as I'll allude to again in a moment, on the clinical panel of WorkSafe. And I think this must apply to other practitioners in the field. So we need to lift our game, basically.
Okay. So you represent the Australian Psychological Society on the advisory committee, David's advisory committee. What's the Psychological Society's position about the Centre of Excellence? Did they welcome it?
Absolutely. Now, when you consider that the APS, as we call the Australian Psychological Society, has 27,000 members out of the approximately 37,000 psychologists working in Australia, it's an important body. And it's a body that absolutely supports the COE and Phoenix's work in it. It sees the COE as the viable means for influencing practice and best practice outcomes for injured emergency services workers. As I said earlier, what is applied to now really has not been good enough. So we strongly anticipate that not only will the APS support this, but other peak bodies, those, for example, that David named earlier, will be equally supportive of the COE. And here's a second take-home message, if you like, Susan. This is a one-in-a-generation chance to get this right. And the Victorian government and everyone involved in it is to be commended. But there's a fair road to go just yet.
And it's not happening anywhere else in Australia, is it?
No, this is a uniquely Victorian proposition or model for how we improve things. There are elements of this that do occur in other states. For example, provisional payments exist in New South Wales, and if people don't know, that's such a boon for workers because you get these treatment sessions whether your claim has been accepted or not, or in some cases claims may never be accepted, but you have an entitlement to a limited amount of initial treatment, and that's a fantastic thing. But as a global package, no, Victoria is leading the way, as it did in the Royal Commission into Mental Health, I have to say. A fantastic piece of work.
So what hopes do you have for the Centre of Excellence then?
Well, I've been musing, wondering, prodding about this for probably 2 decades. I've raised the need for and worked towards the establishment of this. I can't say that the government sought my advice, but I've been poking in various places. And I've done so on the basis that the COE and the SNC, that's the Specialist Network of Clinicians, as David described, is so needed to help guide practice and implement evidence-based treatment. So we can't rely on the past set of arrangements. That's the message. It just clearly has not been good enough. And how do I know this? I know this from various areas in my clinical practice where I get people who have taken the chance to try again for a psychological intervention because their first one was underwhelming for them. I know it from the research. I also know it from the clinical panel. And yes, I am a consultant to WorkSafe, and that immediately and justifiably creates suspicion in some people's minds. I understand that. But I work on the clinical panel to try to improve the quality of what is provided to people. So I look forward to everyone, all stakeholders, having a role in improving the services provided to people.
And on the advisory group that you and I are on, there are some people there that we have lived experience, for example. Tell us about their contribution to the operation of the Centre of Excellence.
Everyone has a contribution to make, right? But often people with lived experience, and I mean this with the best of intentions, they do not know. How can anyone know if they don't have experience of what a good treatment looks like? So this is really about educating all parts of the scheme, if you like, or the situation, so that everyone knows that evidence-based, first-class, gold standard treatment is available. Here's what it looks like. Here's a group of people in the specialist network of clinicians who are capable of delivering this. So people really need to take advantage of the information and the guidance that will be made available through this fantastic project over the next several years.
Because we do hear, I mean, we know, don't we? People get recognised early and get treatment early. Their chance of recovery is so much better. But so many people talk about the fact that they go and see someone and it just doesn't work for them, and then they give up.
Which is just the worst possible outcome, and our role is to roll out early. I cannot think as a human of anything that doesn't go better if you make an early start. I can't think of anything. So getting competent, I keep using the term evidence-based, that is science-based treatment out to people is just so important. And it's been a frustration for all of us who have worked in the field and care about this.
Yeah. Thank you, Tony. I'm going to move on to Andrew Lawrence now to join the conversation. So Andrew is a detective sergeant at VicPol. He joined when he was 19 and a half, and over the past 31 years, he's worked in various areas: divisional crime, sex crimes, homicide, major collision, heavy vehicle investigation. And Andrew is currently working in sexual offences and child abuse investigation team. All of that just makes me cringe, Andrew, at the thought of what you've probably faced in there. Can you start, please, by just telling us from a lived experience perspective, just briefly, a little bit about your struggles as an emergency worker? How did this work affect you?
Well, I suppose primarily what I had to deal with at work is not something I wanted to share with my wife. And I'm very proud to say I'm still married after an entire career. Many police aren't. And look, I'm legally bound not to discuss work in broad strokes anyway, but invariably people feel the need to. And when you don't have an opportunity to debrief or discuss what you've dealt with people other than your colleagues, it can be very difficult when you start to internalise all of those things that you've had to deal with, decisions you've had to make over the journey, and things that you've seen that you can't unsee, and vicariously dealing with other people's grief and the expectation on you to perform to a very high standard for those loved ones left behind, for example, is probably one of the biggest stresses in that sort of work.
So how did you deal with that personally?
Oh, well, I grew up in an organisation that used to debrief over a few drinks. I'm very glad to say that's now not typically the case. We're more of a health-based organisation now, which is a very good thing. It lends itself to when you've got to deal with a problem by yourself and you don't realise that what you're dealing with over a long period of time accumulates in you, and I guess your bucket starts to fill up. And the way I dealt with it was I would typically become more isolated, quicker to anger, shorter conversations with my partner and family, and I started relying more heavily on alcohol because despite all the fun things about alcohol, it's a very good analgesic in the sense that it can obliterate you when you're having trouble sleeping. But then, of course, the health consequences are catastrophic, as it leads to, as everyone knows, substance misuse leads to addiction and all manner of physiological and mental health outcomes as well. Mm. But they're typically that's how I dealt with it.
And that's very typical, isn't it, Andrew? I mean,
look, I think so. Yeah.
Very, very typical. So do you think, I hear a lot of emergency service workers say, they make a definite decision to protect their partners and from the vicarious trauma of the job. And it's like, when they walk in the front door, they shut down. Do Do you think that's actually doing people more harm?
Oh, absolutely it does. When you internalise all of that, all of that, there's no one word for it all. I'll just call it grief, but because it applies across so many different things, it does you harm. It does your relationship harm on so many levels.
Mm. So tell us a little bit about your treatment journey. When did you decide that you needed when did you put your hand up?
Well, I guess I first put my hand up in about 2014 when I was doing some upgrading and running a police station and doing a few bits and pieces. And I really struggled with day-to-day things. And what I now know is I wasn't coping very well at all. And when you're not coping with the little things, the day-to-day things, or things make you or bring you very quickly to anger, things that ordinarily shouldn't, that should be a tremendous warning sign, especially for police, I think. Later, when I was working in a specialist area, we had an embedded psychologist in the unit, and I reached out to her. And on the back of that experience, I was referred to a psychologist in the local area where I lived. A very nice person, but we just didn't click because at the time I was doing all of the things. I was in a pretty bad place, and I was using alcohol too much, and I was not sleeping well. I was juggling that with working on call, and of course you can't drink when you're on call, so you don't sleep when you're on call, and then all these other complicating factors. Now, I didn't particularly get any value out of this psychologist because there was no rapport. I didn't actually trust the person because I didn't have the feeling that he knew anything about what I actually do as a profession. I'm sure he's a very learned person, but he just didn't understand policing. He wholly and solely wanted to focus on my alcohol consumption, but I had so much more to talk about. And so I thought, well, that's that. And I dropped off for about 18 months. And look, the offers of help were there. There was follow-up phone calls from the clinical psychologist embedded in our unit. But it was down to me to reach out for help if I needed it. And I look back now and I think that's probably not satisfactory because I went on my merry way trying to deal with an increasing workload. I was watching people who I was working with fall over. And I've had it in the past where I've lost a couple of colleagues to suicide many years ago, but I was seeing people becoming very, very ill in the workplace, and that was what was getting to me as much as anything else was just the general nature of the work and how we were dealing with our mental health just wasn't really working. And what ultimately happened is, as happens in Victoria Police probably every day, is my workplace was subjected to random drug and alcohol testing. So what became a norm for me, which was to get myself to sleep by having too much to drink, resulted in me testing positive for alcohol on a Monday morning. So that brought with it some sanctions, which the sanctions themselves are really of no consequence. And I must say, hand on heart, my direct, my inspector at the time, a lovely man, simply asked me, he said, "Did you just have a really big night last night, or have you got a problem?" And I said, "No, I've got a big problem." And that was a watershed moment for me because from that point onwards, I was linked into a lot of very specialist people. My GP being one of them, who's a fantastic practitioner, but also my psychologist. And I was with him for within a couple of days. And when it became apparent to me how he was going to treat me was completely different to the way I'd been assessed and treated by the previous person I saw. And we did some different kinds of therapy. And I thought, this guy just gets it. He gets police. He understands police. And straight away, there's that instantaneous trust, rapport, the respect. He's got credibility, and you cut to the chase, and you save so much time, which is wasted time when you're dealing with someone who doesn't actually understand what your profession goes through.
So, along the journey, your treatment journey, what's been most helpful for you?
Well, it's first of all, explaining what psychology does. I think it's dawned on me, and I think it was probably explained to me, that part of the treatment is explaining what psychology is all about. Once you get past that, the two things I found particularly helpful, because I was off for about 6 months before I went back to work, and I reached a stage where I was sort of heading downhill a little bit. But at the same time, I'm being treated by my GP and also by my psychologist. And around that time, I was put on a mild antidepressant. That had a very positive effect on me. But what was probably more effective for me was we started doing exposure therapy. And that was simply going through, and he sent me away and said, look, come back to me with your top 10. And I thought, oh, top 10 what? And I really was overthinking it. And I thought, oh, I can give you a top 500 things which have given me sleepless nights over 30 years. And he said, no, keep it simple. Give us some of the really terrible things you've been exposed to. Give me some dot points only, and then we'll just pick one, and then we'll work our way through it. And it simply consisted of me sitting there quietly, calmly, recounting the incident with my eyes closed. There was the added effect of recording what I was talking about, which I was able to go back and listen to. But I found it astounding just how effective this treatment was for me, because I was able to go back to the incident and walk my way through it, and essentially put it to bed, and essentially say, well, you know what, there's nothing more I could have done in that scenario, and honestly reflect on, well, what I did was right, and I did it to the best of my ability. So it then dawns on you, well, there's really no point in rehashing it all. And I found that once I disposed of those things, a lot of the others that I was preparing to talk about just sort of, they stopped bothering me. So I found that quite extraordinary.
Okay. I met a man on the weekend who'd been a volunteer for 40 years. And he certainly sounds like he needs some of this treatment. And unfortunately, in regional areas, it's not so available. So I'll speak to David about that in a moment. What advice would you give Professor Forbes in setting up this centre so people get the best treatment from the perspective of people like you?
I think we need to have a service that triages the person they're dealing with, so that they're referred to the most appropriate practitioner, the person that's got the right skills. I'm not a soldier, I never have been, so I don't know what it's like to be in a war. I'm a policeman, so I would expect, you know, an ambulance officer, a fireman, or we all see different things and we suffer differently. So a triage system that allows the triager to tap into a network of suitably qualified and experienced practitioners, I think, is the most important. Early engagement. For me, that would be key.
Okay. I also thought it was interesting where you said as a starting point for you was actually understanding what psychology is all about. And I guess that links into the stigma of people seeking treatment as well, isn't it?
Oh, yeah, absolutely. And I'm very pleased to say that I 30 years ago, if this had have happened to me, I think I would have been treated very differently by the organisation, because we didn't do it well. I think we now do it a lot better. I was treated magnificently by everyone in the organisation from every level, including the insurer, which hasn't been my experience previously with a physical injury. So I'm very, very pleased to say that, and everyone that I work with, and I've gone back to work now, and people will say, where have you been, or what are you doing here? And I'll tell them straight out. I said, I had some time off. I was really not doing very well, and I've had some treatment. And they go, oh, okay, well, that's good. So I'm not seeing the stigma that used to be there. And I think a large part of that is because we've got such a young, up-and-coming workforce that it is the way it is now. The days of, I hope, the days of just being told to suck it up and get on with it, and we'll have a chat about it after work. We'll have a few beers. There's still an appropriate time for that sort of thing, but not when you're talking about critical incident debriefing and people going home with things that they really need to offload sooner rather than later.
So, Andrew, somebody's asked a question here, and you mentioned one type of specific therapy, but they've said they're curious to know if Andrew is happy to share the specific therapies that were helpful. So what was it you called the one that you did where you looked at past incidents? What was that?
It was called exposure therapy.
And is there others that you've done as well?
Oh, look, probably the exposure has been the most useful. But look, when you sit down and speak to a practitioner who gets to know you pretty well, you can generally have a conversation about what's been going on in your life, little milestones and hiccups, and how you're related to certain things, and situations you've been through with your family or whatever, that before, when you weren't well, you reacted differently because you weren't well. It's a bit of guided self-discovery, if you like, is the way I sort of felt it. But the big ticket item for me was the exposure therapy, because that really sort of busted through what my core problem was, which was I couldn't sleep because I'm getting all these intrusive thoughts, and stuff would just come to me in the middle of the night, whether it be, I've got a trial in 6 months' time for this particular nasty job, or I've got to catch up with a person, or I'm rehashing something that I've been through 10 years earlier for whatever reason. But once you deal with those things in that way through exposure, I found I was able to put almost all of it to bed.
That's fantastic. Well done. We might bring David and Tony back in and have some time for questions. Thank you, Andrew. That was really, really terrific. I'll start by asking some questions while people start thinking of their own. So, David, you talked about the centre is not a bricks and mortar place. I know that there was some confusion over that. People sort of see the need for a bricks and mortar place. So how will this help overcome that?
Well, look, so the centre itself isn't a bricks and mortar. What it is aiming to do is to do exactly the things that Andrew's described and that Tony has described, really, which is to make sure that with clinical services in the community, when emergency workers go to see their GP, their psychologist, their psychiatrist, for example, in the community, that they're seeing somebody who understands the work they do, understands the organisations they work in, what goes with working in organisations like that, what kind of experiences people have in organisations like that, and what are the mental health consequences of that. And are then skilled up to be able to provide the best possible treatments. So, for example, Andrew beautifully described exposure therapy. And exposure therapy is one of the strongest evidence-based treatments we have for particularly trauma-related disorders or anxiety problems, which then secondarily address things like sleep. But they really, what Andrew's described is the difference between, in the first instance, seeing someone who perhaps wasn't aware of the issue of policing and what that was like, and secondarily didn't necessarily provide what was the best evidence-based treatment, and what a difference it was when, I don't mean to speak for you, Andrew, but if I understood what you were saying, is what a massive difference it was when you saw someone who understood what policing was about, the nature of police culture, and also what was organisationally required, and then was able to deliver you an evidence-based treatment that really mapped on right on to the difficulties you're experiencing and what a turnaround that can be in terms of people's lives, personally, at the family level, at the organisational and occupational level. So Susan, in answer to your question, it's really about, the Centre of Excellence is about building up practitioner to support a specialist, that triage and network of specialist clinicians across the state that emergency workers can tap into, who are part of that network, so they know they're getting someone who understands them, their experience in their organisation.
Sorry, the triage comment that Andrew made, is that what you're referring to as centralised intake service?
Yes, that's right. So, for example, we'll get the referral in, and then that will be triaged through some questions. Who's the best practitioner in your area who's aligned with the difficulties that you're experiencing coming from the organisation that you've come from? So that intake service will be able to provide that triage to the range of different clinicians out there in the field to try and get that best match where possible. That's both around what problem, but also might be geographically based about where you are and what that means, and trying to get care as local, as close to home. Probably important to say is we recognise each of the agencies themselves, each of the emergency worker agencies have their own in-house clinical unit. So this is building up the clinical side in the community that sits in a nice partnership with the clinical units within the organisations. And we would be expecting that there's a good interchange and kind of bi-directional conversations between those organisations as we learn things in the community that can be fed back to the organisations and the agencies themselves as well. And that allows for connection between what happens in-house in that first point of contact, and then as when there is referral to the community, ensuring that that's aligned, it's connected, and it's very organisationally informed as well as clinically informed to get the most out of that care. And as Tony has mentioned, as Andrew mentioned, the importance in that first contact when you're actually reaching out to care. Sometimes, and thank goodness, Andrew, you reached out a second time. I know it was circumstance driven, but sometimes people just reach out once, and if we don't get it right the once, they don't try again. And so it's so critically important that we get it right the first time.
And of course, the clinicians working within agencies are all members of groups like the Psychological Society anyway, so they will be brought in as part of this.
Tony, they'll be connected with it. Yeah, they'll be connected with it. The network is for those services in the community. It's available as a resource for the agencies, but it's not looking to lean into the agencies themselves.
No. So, Tony, would you like to comment on that question that was asked before, where Andrew talked about somebody asked a question about specific therapies that are helpful for people from emergency services?
Very happy to, Susan. If I can make one ad-libbed comment about the bricks and mortar. David's outlined the network beautifully, right? But this is about quality first, quality second, quality third, quality forever, right? And you can have a beautiful purpose-built building, but if it doesn't have the ghost in the machine, the culture is not right, it doesn't matter. So think of battlefield hospitals in tents, right? They're not beautifully built things, but amazing things happen in them, right? So I don't think it's about bricks and mortar in toto. I think it's about who works in these places and their willingness to adhere to the evidence base. And when they do, it makes a real difference. Culture is really, really important.
Yeah.
So to go to the question of evidence-based treatments, there are at least 3 or 4 in the area of PTSD. Our number one evidence-based treatment, as David has said, and I'm a northern suburbs boy, and you can take the boy out of the suburbs, but I use the length of the Flemington Strait to actually indicate the distance between exposure and all other treatments. There are some really good treatments like EMDR and cognitive processing therapy, but these are PTSD-specific treatments. But whilst they're very, very good in their own right, in my opinion, this is my opinion, and I will own this, they are simply not as good as exposure. And the reason exposure is not applied is not because people like Andrew don't ask for it. It's because the practitioners don't have the confidence the skill, the ability. They have mistaken assumptions about how talking with people and working through with people what's happened to them is going to make them fall apart. I have had so many clients say to me, I'm really annoyed.
Oh, is that just me or has Tony dropped out? I think Tony might have frozen there, unfortunately.
I'm back.
Yeah.
I hope
back?
that point was clear. People not getting exposure is not the decision of clients. It's the decision of practitioners who should know better, and they don't do it.
Okay.
So EMDR, really strong evidence-based, but not as good as exposure. So cognitive processing theory, which has elements of exposure in it, not as good. And for complicated cases, we have other treatment regimes. There's one called STARE from the States, which has exposure in it and education, all kinds of things. So we've got this armamentarium of things that work, but practitioners don't use them. And that's what the COE is about.
Yeah, fantastic. David, a question for you. How do you see the Centre of Excellence working with the ESF? We both want to improve mental health outcomes, but you're focused on the practitioners. We're focused more on early intervention stuff.
Yeah, and I imagine that the two will work very closely in terms of kind of bidirectional communication in some respects, really, which is, we'll learn a lot in terms of working with the practitioner network and what's working, what are some of the early signs. We'll learn a lot about the journeys of those who have made it into the clinical network, and we'll learn a lot about what's worked and what might be a better pathway into care that we can then learn from that and advise the agencies and advise ESF about what we're learning. Also, I'm imagining the ESF will be able to tell us about how they're identifying people earlier, how the agencies are identifying people earlier, what's best treated in-house within the agencies, what's best worked through as an education program through ESF, and when then the optimal point is to be able to refer into the network. It's, in some respects, we can see these things operating in terms of the stream, in terms of how upstream or downstream it might be. But it's only one stream, and the critical part is ensuring that there's good communication as each of us learns more about our domains of activity and keeps the other informed around that. And I can imagine the whole system evolving quite seamlessly with that level of communication. And, I'm pleased to say, from our perspectives, we have a strong respect and a strong engagement with ESF through you and through the organisation. And we're really, really buoyed by the partnership that we have.
So there's definitely no reinventing the wheel by us both doing similar things. And I think that's an important point to make. In fact, one of the things that came out of the advisory committee when we met last time was something that ESF could do to help inform the work of the COE, and that was to have a look at the scope of trauma potentially across the agencies in the different roles. And so we're starting a piece of work on that we can feed into the Centre of Excellence. There's no other questions here on the side, but is there anything else, Andrew, you would like to say in finishing up?
No, not that I can think of. Thank you.
Okay. Tony?
One thing, I think implicit to all of this is the role of employers. And I think we've all spoken to it in a way. And I do believe VicPol, as an example of an emergency services employer, is trying hard. But any work that either as part of this project or we can all keep in mind is the ability of agencies to be really thoughtful about their workers. And I get to write lots of things for the APS submissions, and I look over productivity commission submissions around bullying in the workplace and white-collar occupations, emergency services occupations are too often troubled by this stuff. So we treaters have got a real job to do, and we do it willingly, and the COE is fantastic, but employers need to look at their behaviour as well.
Absolutely. And what I found interesting about something that Andrew said is that when he had that random drug and alcohol testing, the person who was leading him at the time said to him, what's up here? Have you got a problem? And it really does come back to that conversation and knowing your people and understanding what's going on for them, you know, as an emergency service worker, but more holistically, their whole life, you know, because when we come into the door of the police station or the fire station or wherever, we don't drop everything else and leave it behind. We bring it with us. And as David said, everything interacts. David, would you like to say anything else?
Just look, my final comment picks up the words that are behind you on the banner there, Susan, which is better together. And that really kind of summarises it for me. I think that, you know, there's genuine focused goodwill and intention around collaboration in relation to this with ESF, with the Centre of Excellence, with the emergency workers, police emergency workers themselves, the agencies, the health professional organisations. There's a determination for us all to work together to make sure we get this right and to maximise the outcomes, and from the government also. Really, it does strike me that this is one of those moments in time where everyone's pulling in the same direction, and it really feels like a potential turning point.
Thank you. Thank you, everyone. And a reminder, thank you, David, Tony and Andrew, most of all, obviously. Thank you to everyone who's participated today. A reminder that there will be a recording of this session available on ESF's website later in the week. Thanks for your interest. Stay safe wherever you are. And next time we'll be speaking to people from Charles Sturt University about a study that they did into the impact of COVID on emergency service workers. Thank you. Have a good day. Bye-bye.